direct primary care lets you prioritize family in a different way. Now, my practice has been open over 4 years, and I think that there are pros and cons. I'm very open and transparent and balanced about direct primary care. I love setting my own schedule. It's incredible. If my kids are sick, they come to the office and hang. There's so many benefits. I'm a room mom, a room parent for both their classrooms and have been for both of them ever since they've been in school. So that flexibility is beautiful, and I wouldn't change it for the world. It is a little bit more sometimes 24/7, depending on how you run your practice and how things are set up, and if you're solo with no staff or if you have help at the practice. So there are some ways that direct primary care can leach into life in a different way. I'm not usually up at night doing notes the way maybe I used to be when I was seeing 20 plus people a day. But running a business takes time, and you have to find hours to do that. And patient care can be kind of 24/7 when you've got a sizable panel. So there's pros and cons, but to me the pros vastly, vastly, vastly outweigh.
Hello, I'm Dr. Matt Howie, and welcome to the Doctor's Lounge. Today, we're going to learn a little bit more about direct primary care. If I said DPC in a room full of primary care providers in our county, only a handful of them would be able to identify the meaning of the letters, much less describe the direct primary care model of care delivery. Expand that question to all physicians within our county, and the number goes even smaller. To understand how this model of healthcare delivery is somewhat counterintuitive, you need first to understand how primary care is funded and delivered in our country. In very brief terms, delivery of primary care in the United States is not sufficiently funded to meet the demands of our population. As a result, this underfunding is not able to support independent practice. There are a number of historical reasons for this, but the ultimate effect is that primary care increasingly exists as part of larger healthcare systems and is subsidized by the funding of specialty care along with ancillary services such as imaging and laboratory services. Operating under this framework, primary care as embedded in health systems results in shorter duration of patient visits, limitations in the scope of practice, and the encouragement of physicians to use ancillary services. All of this is done to increase patient volume and maximize utilization of billable services of the organizations, thus underwriting the delivery of primary care. In response, some providers of primary care have explored ways to deliver primary care in a way that is both more patient-centered and financially viable on its own. In its purest form, direct primary care is a model for the delivery of primary care that allows for direct engagement between provider and patient without involvement of third-party insurance companies or large health systems. DPC is an approach to care that has steadily and impressively gained traction across our country. The conversation that follows between three providers of direct primary care hopes to outline the core principles, the benefits, as well as challenges of providing DPC in our present medical environment. How did you end up getting into medicine, Christina? Tell me, Dr. Dahl.
So I was not, you hear a lot people who decide they want to go into medicine very early in childhood. That was not me. My parents, my whole family is non-medical. Well, now my sister and I are, but before that, no one, we don't have any medical family members. So I did not grow up around medicine. I actually decided when I was a senior in high school, I was in a science and tech program. And as part of that program, we did a year-long internship as seniors. And we were right outside of DC. So people did them at NASA, NIH, and mine was at Children's National Medical Center in Washington, D.C. Oh, okay. So because I was obviously 17 years old, I wasn't doing anything medical. I actually worked with the art therapy department. And that was my first time really spending any significant, other than being a patient, spending time with patients and being at bedside. And it just sort of clicked for me that I felt very at home, very comfortable working with patients, and loved the art therapy aspect a lot, and knew that I wanted to bring that sort of humanity to medicine, but also loved the science and learning what the patients were there for and kind of listening to the doctors and the nurses. And so that I didn't decide until I was in my teen years, but it stuck with me ever since.
Oh, that is awesome. What a great kind of story of getting into an environment that otherwise you would not have been into.
Yeah, that exposure, I credit, because I without that internship, for me, that was the deciding factor, and I really wouldn't have had the opportunity to explore medicine without that. So
That's awesome. But you, Lauren, tell us a little bit about your origin story.
Yeah. So I am the complete opposite. I was like born wanting to be a doctor. Ever since I was little, like my parents said, you just always wanted to be a doctor. They have pictures of me when I was like 2 and 3 years old playing doctor. I had all these scrubs saying like doctor in training. And there's this one picture of me walking on a balance beam at a park and it says doctor in training. It's one of my favorite pictures. I was probably 4 or 5. But it was just kind of ingrained in me. It was a calling. And so I don't think I have thought about doing anything else in my entire career. Like there was a point in time, guidance counselor had told me, oh, you're not going to get into some of these schools. You're not going to do this. You're not going to do that. Yes.
What is it telling us that?
I was so embarrassed when I was in high school. I was like, I'm not telling anybody because I was like, oh my gosh, I'm not going to say it. They said this. Later, talking to other high school friends, we found out that the guidance counselor told us everybody that same thing because they wanted to have a high matriculation rate, saying, oh, look, all of our high school seniors, they are going to college.
It's all about the numbers.
Yes.
Yeah.
So, but fortunately, like my parents, they've always been so supportive. They're like, you have only ever wanted to do this. You have to follow your dream. So I did. So I can't tell you why. That's just.
Wow, that was kind of
It's
almost like
born
it's in
into
your
me.
DNA.
Yeah.
So now we're going to figure that out.
Yeah.
You have even a different take on this, Quincy.
I don't even know that I do want to be a doctor. To be honest with you. I mean, I grew up around it, so I'm sort of the opposite in the sense that I was very immersed in medicine. My parents were both in healthcare, and so it was like the main job that I saw growing up. So I identified with it and whatnot, but I heard the same sort of messages like, you can't do that. Nobody can get to med school. So I never really admitted I wanted to do it because I didn't, you don't want to try and do something that you're not going to do.
Yeah.
And so I tried to find other things to do instead, and I couldn't find anything else. And I had been anxious enough to keep my grades up, so eventually, a couple years after college, I applied to med school. That's how I ended up in medicine.
Funny.
Mostly just because I wanted to do the job because people seem to like doing it.
I love how we all have different stories.
Yeah.
Though. Yeah.
It's funny.
Yeah, I mean, it's funny. I mean, when I was in residency, like your dad's practice was one of the practices we covered on the inpatient unit. So I knew Harberger before Quincy Harberger. So back in the day.
And I grew up with that. I grew up with residents in my living room for things like journal club.
Yeah.
So it just seemed like the way things were, but it wasn't like appealing to have, no offense, residents in my living room. It's-
I got you. No, I mean, when I was in middle school, I took one of those aptitudes, and they were like, wow, clearly this is the direction your son's going, kind of thing. And I wasn't 100% sure, but then it sounded like a good idea. And then, unfortunately, my father got very excited about the idea of his son, the doctor, because no one in the family. And then I did what all adolescents do when their parents decide that this is a good idea for them.
Never mind.
I say that I don't want to do it. So I kind of ran away from it for a little bit. It was my Nineveh, right? I just didn't want to go. And then I found that when I was in college, I was enjoying doing the touchy-feely humanistic stuff far more than I was doing the business school program that I was a part of. And I wasn't showing up as prepared for my business classes, but I never missed a shift when it came to working at the homeless shelter. So that was my tip-off that maybe there's something different. So I talked to my teacher parents, and they were like, you don't want to be a teacher. Kind of like what you're doing, like you don't want to do it. So they were pushing me away from that piece, but the medicine thing just intrigued me, and I think it was a great way to combine that sense of I understand the science base, I'm pretty good in those spaces, but then understand the humanity of it as well, and I think that's why family medicine ultimately came in. Was there any other kind of thoughts besides family medicine? Because we're all family medicine physicians here at this table.
Trauma surgery, believe it or
Trauma
not.
surgery? Yeah.
Yes. I was between those two. And ultimately, so we both went to Maryland and shock trauma. I didn't realize that you did too. I'm sorry.
I didn't go to Maryland, but
you
of course
said,
it's shock trauma.
Yeah.
I know
So,
Something about those pink scrubs really.
yeah.
Draws you.
Yeah, but David Gens, he's a wonderful, talented surgeon. He's kind of like just a step down from Dr. Scalia there, but he's phenomenal. But he said, you would make a wonderful, great trauma surgeon. the end of the day, though, I think with family medicine, it brings in all aspects that I truly care about. There's still, I don't want to say trauma, but there's always the unexpected. You know, there's procedures, there's the continuity, there's everything that I really liked there. And I don't know if you guys all got this too, was why family medicine? You're too smart to do that.
Welcome to Maryland. That's their
Yes.
dirty secret, right?
Yes. And I was like, no, but you almost have to be smarter to do family medicine because you have to know a little bit of everything. But
Yeah.
it's just kind of like that old school family doctor that, and I think that's what we're kind of all doing now too, that we're bringing to the table.
I had a hard time too. I liked a lot of different things. I loved obstetrics, at Maryland, it did a lot of my sub-Is and like maternal fetal medicine and stuff like that. Really loved the operating room, loved procedures, loved all of that. And actually I struggled with that even as a resident. Found myself like when OB needed coverage, taking extra call, or like when co-residents had babies due, continuity patients that were due and they needed some coverage, I would always kind of take that on. So even as a resident, I struggled a little bit, but ultimately for me, I think sort of that old school mentality was a big part of it, but also just I loved caring for the mother-baby dyad. Like I really, really loved that unit, kind of the parent-baby dyad. And I did, they always tell you when you're trying to decide, like if you want to stick with the parent or the mom, you're an obstetrician, and if you want to go with the baby, you're a pediatrician. And I was like, what if I want to care for both? And they're like, then you're a family doctor. And that has really held true for me, and my practice now cares for a lot of young families and newborns and their parents. So
That's fantastic.
still a big part of what I do.
Yeah. I think I just always liked family medicine. General surgery, if I was going to do something else, I feel like I identified my first clinical rotation in my third year was general surgery at the Lebanon VA. And my senior and both the interns were awesome. And I really liked how they did notes and how they talked quickly and got stuff done. And
Not like our notes.
I'm serious.
No,
So by the time I got to York Hospital to do my medicine rotation, they're like, these notes are terrible.
Yeah.
You want to do medicine, you said? You're already like a surgeon. I remember that, but mostly what I like is when I was a kid, I used to read the James Herriot novels. You ever read those? All Creatures Great and Small. He's a country vet, and people pay him with like eggs and glasses of beer and stuff.
This is
or butter
all the way.
and that was
really,
what I always had in my head.
Barter.
Yeah, 100%.
Which, as it turned out, that wasn't what I stepped into once I trained and everything. But that's what
Yeah.
I was thinking when I was thinking that family
way.
medicine.
So that's a great kind of stepping off point, because
Yeah.
I think we all have our vision on what family medicine would be, and I think at its core we're all still committed to that ideal of caring for a family, multi-generational, all those sorts of things. But something changes sometimes when you finish your training. You have to go out into the real world. So tell me a little bit about your experiences in private practice early on, and how maybe they're changing now as your worlds are kind of evolving a little bit.
Yeah. I thought that was difficult. Because I really had in my mind what I wanted to be like as a family doctor, what that scope looked like. And as residents, we're so full spectrum.
Right.
We do all of our own procedures because we're learning. We do our own deliveries. Because we need numbers, and we're kind of in that training process. And then you get into practice, and your visits are so short, and you're just like patient after patient after patient after patient. And sometimes it comes down to like, do I do this procedure? Do I refer out this procedure because I don't have time to do it? Or I'm booked out 6 months and they need this now and it's not fair to make the patient wait, or whatever the case may be. And I found myself feeling often like I wasn't getting to practice the full scope that I had trained so hard to learn. Like I wasn't getting to use the skills that I had developed, even though I wanted to. It was just I thought that was tough.
Absolutely. Yeah.
Yeah, I think the model doesn't necessarily support that
Right.
kind of family practice, scope of practice that we all
Right.
did. I mean, when I finished my residency, I worked for 3 years in Northern Arizona in the Indian Health Service. And, I covered the emergency room, I delivered babies, we stabilized trauma, I took care of babies, I did primary care. I kind of did as broad a family medicine as I could, but it was because of the geography and the necessity of that space. But in an environment with the rest of the country, how the rest of the country works, you get prioritized. The priorities are different, and the business model really does start to shape what you do.
Right. And even what patients expect, I feel like, is impacted by that, because if the narrative is that family doctors, all they do is provide referrals. Like you hear that. You hear that we're
You're a
just referralists. Right. Well, that's all we do all day is just put in referrals. And if that's what patients think, then when they come into your office and you say, I can do that lesion biopsy, I'll do your joint injection, I'll do your PAP, I'll do your, sometimes even patients are like, I'll see my, whatever specialist for
Right.
that.
Right.
And it's hard to convey to them that like, no, we're very, very trained and capable of these things, but that's not, it's just not the model that
Right.
most of us end up in.
And I think the other kind of issue, almost to piggyback, is, oh, you're a family doctor. I'm going to see you for my annual preventative exam. And I can bring up every single question that I have. And it's free.
Yeah.
But then people are shocked to learn that, well, no, it's actually not free. Your annual visit is all prevention. And the other zillion things that we save to talk about, that is billed as an E&M visit. So then you're on the phone, or office managers, somebody's talking to them about, oh, well, why did you charge me twice? I was only here for one issue. So again, it's kind of like what the model is, what patients expect, what the, everything just kind of collides to be.
And that goes back a little bit to what Matt said about you have it changes how the payment model changes how you practice. So what ends up happening is you don't do pap smears at the same time you do wellness visits because you can't charge for them or whatever, or it's too much. So you end up practicing different, which makes your care not as good, which further sort of like degrades
Right.
your profession.
And the patients pick up on it, and especially now with more transparent billing, then suddenly it becomes you're a part of the system, and they're on the opposite side of the relationship that you want them and need them to be to provide that good care.
And it's hard because we understand, like I think every family physician understands the frustration of you can only bring up one problem at this visit or two problems, right? Like how many offices have a sign that says something to that effect? And we know how maddening that is for patients, especially if they can't get in for months and months and months. But at the same time, we're trying to function on this tight schedule. We're trying to make a living, like we're, what every other specialty is doing. So I think those things are so at odds that it's just challenging.
Or we cram more into our own schedules.
Yep.
And then, because I think just by nature, that's
Yep.
how we are. And then our lives start dwindling. And to make patients' lives better, it's not fair to
Right.
anybody.
Yeah, we've spoken about our professions here, but I think the hidden group that always is supporting you, but also impacted by your work world, is the personal life that,
Right.
that is absolutely impacted. Was there anything in particular that you guys have learned? As a male, in this field, I reaped the benefit of a spouse who says, I will support you. I will be in this space. But also, I've been in the scenario where I am the primary breadwinner, and so therefore I can't take as much risk in other things. We'll talk a little bit about the risk that you take when it comes to these things. Suddenly it's like, well, so what are the benefits that go with that? And what are the other aspects of it too? So you get pulled into a system, and it's a system that benefits you as a physician greatly. At the same time, it's one that kind of owns you to a degree, and it shapes what you do because by necessity it needs to for its existence. I don't know if you guys had how it has shaped your family life or your personal lives.
It's so much better. I've only been doing this for 2.5 months, and my family can already see a huge difference. I'm happier. I'm more present. The running a business is a huge thing that we can talk about, but so there's still stress, but I'm not bogged down by 1.5 zillion tasks. I'm not bogged down by trying to delegate, okay, well, what does this, what goes here? I'm not going into work. I'm not leaving the house at 5 a.m. anymore. I get to set my own schedule and try to be more present for them. And kind of to your point, we have a reverse household. My husband's a stay-at-home dad, and it is phenomenal. And I think one of the things that has been shown to predict the success of a DPC is a supportive spouse. And my husband is 100% on board. He is so supportive. He is like preaching DPC to anybody who will listen. But he also does all the household stuff. He does the laundry, he cooks, he cleans. He's the kid's primary person. I still do the mental gymnastics with it all. But she's like, yeah, no offense. But he's been fabulous, and he's also helping with parts of the business side too. So it's the best thing I've ever done.
I think that's it's a big conversation in terms of just like building a family within medicine, what that looks like, especially I think for women in medicine.
Absolutely.
I feel like I was lucky as a resident because there were residents before me who had children, and that made it a little bit easier to navigate that. But certainly, when you start to grow your family, everything changes. Priorities change. And so many, I'll at least say, women in medicine, you are forced to kind of back up, take a step back, because there's just no way to do every single thing. So we go part-time, we cut back on hours, or you know what I mean? You outsource, right? Like how many posts do we see in women Facebook groups, physician Facebook groups, about like, how can I juggle all these balls in the air at the same time? And I certainly think that direct primary care lets you prioritize family in a different way. Now, my practice has been open over 4 years, and I think that there are pros and cons. I'm very like open and transparent and balanced about direct primary care. I love like setting my own schedule. It's incredible. If my kids are sick, they come to the office and hang. Like there's so many benefits. I'm like a room mom, a room parent for both their classrooms, and have been for both of them ever since they've been in school. So that flexibility is beautiful, and I wouldn't change it for the world. It is a little bit more sometimes 24/7, depending on how you run your practice and how things are set up, and if you're solo with no staff or if you have help at the practice. So there are some ways that direct primary care can leach into life in a different way. Like I'm not usually up at night doing notes the way maybe I used to be when I was seeing 20 plus people a day. But running a business takes time, and you have to find hours to do that. And patient care can be kind of 24/7 when you've got a sizable panel. So there's pros and cons, but to me the pros vastly, vastly, vastly outweigh.
So all of you reached that kind of conclusion where you said, for whatever reason, I want to pursue this unique delivery system, or however you would describe. Can any of you give me kind of like the definition of DPC? If I was reading the textbook of DPC, give me the shortest elevator speech version of what is DPC to somebody who's
You've
not
probably been doing this
experienced
day in and day out lately.
I have been doing this day, so full disclosure, I'm not actually doing direct primary care. I'd just like to, and I'm in the process of getting it set up.
before. Okay.
Probably not till the beginning of the year would I actually be out there having these experiences where I'm learning about the pros and cons directly.
But we can still yap about
But
it.
we can yap about it, and the motivation is because direct primary care is what it is. It's direct primary care. You're doing primary care. So from my perspective, my job is clear. When I'm working in a sort of a corporate environment, my goals or what's driving me to do things is different than just the primary care. I know that there's a whole system that's trying to operate, and we've got a bunch of different stakeholders in this system, and I want to support the team. And so I may end up supporting things being done a certain way. I think it's a terrible idea. It's a waste of my time and a waste of the patient's time. But I'm doing it because I understand it's a bigger process and people will benefit on the whole. So to me, direct primary care is taking care of patients with transparent purpose, and you're doing what you're doing for the reasons that you're doing it. You're not trying to explain away why you're billing something in some racketeering sort of way.
Yeah, you guys have alluded to this a couple of times, but there are different models of DPC, different versions of it, and people always kind of conflate DPC and concierge, and that's always the thing people talk about. But it really is bypassing insurance or third-party billing.
Right.
And for physicians, they understand this. I mean, there is a lucrative part of third-party billing, and then there is a challenging part of third-party billing. Did that play a role in what you guys were doing, or the choices you made?
And partly, and one of the things that I tell people is that with direct primary care, kind of like Quincy said, it's about the patient, but I tell people I contract directly with you, not with the insurance companies. So that's kind of how I separate it in my mind too. And I say it's transparent pricing. You have direct access to me, and you pay me directly, but you have access. You have my cell phone, you have my email, you can see me virtually, you can see me in office. And then the transparency, the access to care, which is huge. But then also, not all DPC offices offer it. Some do. I do in-house blood work. I do in-house prescriptions. So there's also these markedly discounted access to medical care too. And so I think a lot of that kind of plays into my elevator pitch in terms of what direct primary care is. And the things that we're able to do and bypass from insurance system too. Even having patients say, you know what, I called a few of these different imaging facilities and you can get self-pay for this price. You don't have to go through your insurance and reach your unattainable deductible, you know, so you can bypass it in so many cases.
But you're right that I think there's a lot of confusion out there about what direct primary care is. And even amongst our physician colleagues, I think there's a fair amount of confusion. I'll see people mention DPC on social media posts and things like that. And it does often get kind of lumped with concierge. And there's a lot of overlap. There's a lot of overlap there. So it's for good reason. But I think it's important that, I'll say particularly in York, where we're all, where we're practicing, that the affordability of it is conveyed. So I sometimes will lead with that because it's almost like you're taking concierge level care and access and communication and appointment length times and same and next day visits and all of those things that are kind of the biggest selling points of concierge, and you're making it more affordable for average families, because that is really, the price range is pretty vast for DPCs, and a lot of it has to do with what community you're practicing in and what cost of living is like and all of that. And there's strong opinions about what those numbers should look like, but I think on the whole, it's more cost effective for families than concierge care. And so I like to explain that to people because I think that sometimes just knowing that a physician is outside of the system scares patients away, because they're like, that's going to be too expensive for me. That's going to be, that's concierge. That's not in my realm, that's not something I'm going to spend extra on. So patients are always very surprised, I think, by what we offer for the prices that we set and how transparent it all is. Because when you're that open about how much things cost and what you're passing through to the patient, I think people just feel better about it, regardless of what your price is. Like, they just know that you're kind of, most of us don't mark things up much at all, and we kind of just pass those savings right through.
Yeah, I was thinking about we're kind of in open enrollment right now. And
Yeah.
so this has been like on my mind.
For business.
So there's a couple of questions about that, but this idea of this emergence of the high deductible healthcare plan that's getting much more popular now, which I call like the car accident insurance plans, right? I have it because I have to have it, but God forbid I have to use it because, to get to the unattainable deductible on the other side. That's kind of crazy, in terms of the cost that'll go with it. Is that a conversation? And certainly, I will say, before I kind of leave this out there, in my role, I work training residents, and so we're definitely in the insurance land. People are paying, even with insurance, are paying a lot of attention to cost. I mean, this is something, because of the high deductibles and other things, and I find myself having to go a lot, where it's not as transparent to me, so I can't make it as transparent to them. So I completely see where that would come and be a benefit.
It's wild thinking back to when, I was working at a, hospital-based kind of employed physician role. I didn't know what anything cost. I couldn't tell. I just couldn't tell people. I don't know. Do you feel like that? I didn't feel like I knew what anything cost.
I didn't know what it cost. I was shocked when people would say, I got a $400 bill, and that was not uncommon at all.
And you would feel so bad because you weren't.
It was medically necessary.
Right. And you felt like I'm providing the care that I still think is relevant and indicated, but people would come back to you and share the costs, and I would be horrified. But there really isn't a lot of transparency. There's not a lot of training about what things cost or what they actually cost, and then how that gets kind of adjusted. So when I was setting up my practice and getting, making lab arrangements and imaging arrangements, I was simultaneously so excited and a little bit horrified that I didn't know these things. Because you're right, and people are struggling financially, and I think that, every day, I don't know, but like every day, I feel like I have this conversation with people talking about if the practice is right for them, what they can expect cost-wise, what insurance might pair best with DPC is a common question that I do a meet and greet call with every potential patient and family. And that's a common question. Like, we're looking at open enrollment. We're trying to decide what to do, what would pair well with something like direct primary care. But I think the predictability of it is such a huge, important factor. And that way, it's like a gym membership. It's like, here's the flat monthly fee. This is what you can expect. And that, like, reassurance, and then the fact that any additional cost, if we're ordering labs or imaging or whatever, is completely transparent, that just really, I think, is helpful to people when they're navigating, I don't know.
It is. And I think when I do meet and greets too, and I don't offer medical advice during those meet and greets, but sometimes if a patient says, well, I saw that you had a post about, meds at lower cost. Can you tell me what you can get a medicine for? So I'll say, yeah, sure. And it is. When I first got my first shipment of meds, I was sickened. Meds are pennies, and they're upcharged so much. I have one patient, I can't remember the exact numbers, but I want to say it was about $420 that she paid on meds every 3 months. And we got that down to just over $100 every 3 months using my pharmacy. And so the cost and her savings almost pays for the membership itself, which is insane. Or if you have labs 2-3 times a year and it's $400 each time, that's your membership, your savings, because I can order those same labs for generally under $30.
Or one visit to urgent care, or one saved ER visit. Like,
Yes,
sometimes it's hard. People will ask, how do you grow a DPC practice and advertise? And sometimes advertising is hard because it's such an experience, and it's difficult to just put on paper and give people a real feel for it. So I think patient stories and people spreading word of mouth, things like that, is so important. Because it's true. So often it's like, well, we kept someone out of the ER just one time, and that pays for their year because of how expensive things are. So yeah, I think it's pretty incredible. But it is certainly eye-opening, and you do feel a little bit
Guilty.
Yeah, just
You're making me feel bad.
I know.
I'm just telling you.
Why haven't I been feeling guilty? I feel guilty.
No, I mean, when you order labs and you're like, hey, what is the right test to order? Or you're ordering imaging, and that is exploding right now in terms of people saying, we need to do calcium channel, calcium scores and all kinds of stuff there. And I'm like, well, that is great. Every lecture that I go to those things has zero information about the cost related to it.
Those cardiac calcium scores are not covered by insurance. However, usually $120 to $200.
I was going to say sometimes $99.
Yeah, those are the best tests ever. It's all the other CAT scans that are the diagnostic.
And why do you think that is? Why do you think this distinction? Because I have my own
Because they're not
assumptions.
covered by insurance.
Because the key is the insurance, right? I mean, there's an upcharge when it comes to that.
Yeah.
I remember when I was being recruited to come back, and I was speaking to the head of the medical group, and he was talking about insurance. He was trying to explain it to me, and he explained it in the terms of, how much does it cost to repair your car after it's been in a car accident? And it really is like, well, what kind of insurance do you have? And healthcare very much operates in that thing, like what insurance do you have, and therefore that will kind of set in a framework around the cost. And I remember relatively soon after that, there was a time where my employer was expanding, and there was a practice in Lancaster County, a hospital in Lancaster County that they were acquiring. Acquiring is a dramatic term, but they were merging, or whatever the proper term is. But they had a lot of experience in actually transparent pricing. And they were like, well, why is that? And they said, the plane community. The plane community self-insures. And so for them, they've been negotiating for the cost of procedures forever because that's how they operate. It never changed. And it actually taught the system a skill of how to have more transparent pricing, because up until that point, there was no motivation for it. Why would you do that? This is a population that needed the care and expected it.
Right.
And so it'll be interesting to see if there are similar kind of levers that occur that allow more transparency and clarity about pricing on procedures or lab work or medications.
That car insurance kind of comparison actually comes up a lot. And it's interesting because one of the things that DPC physicians will say is, you have your car insurance for accidents, but you don't use it to get
You
gas.
never want to use it.
Or an oil
You
change.
don't get it to get an oil change. And that's what DPC is. So like for the day-to-day stuff, you don't use your car insurance. You use your car insurance, heaven forbid you get smashed, but you don't use it for these little day-to-day things. You just pay what it costs. And that's kind of what direct primary care is doing in the primary care landscape, is like, here's a predictable, transparent, cost-effective way for the day-to-day. And then, sure, obviously, it's great, to have catastrophic plan or something for in case, something big comes up unexpectedly. But for the day-to-day, is it worth having that sort of opaque surprise bill sort of stress of it all?
Not at all.
And I think patients are starting to say, no, no, it's
completely
not.
not worth it.
One of the big things with the high deductible plans, and one thing that came out of the One Big Beautiful Bill, is that starting January 1st, Patients will be able to use up to $150 HSA funds per person or $300 per family per month for DPC, which is a huge win for DPC.
That is a very big.
It was always a very gray zone, and it was hard because people would call in asking about that, and there wasn't clarity. And we would kind of say, talk to your HR team. We kind of have to.
Probably not going to get on it.
You want to never, you'd never want to give bad advice. But it's nice to have that clarity.
Oh, absolutely. I remember early in the discussions of DPC, there was this interesting kind of back and forth that occurred because sometimes insurance companies in the past, I can't tell you what's new, will approach DPCs and they will say, can we pay for, it's this weird kind of access point. So it's not being a fee for service kind of model, but for them is for our high-risk patients, our high utilizer patients.
Right.
For situations we're looking for help on because we're losing our shirt on it from a
Right.
business standpoint, there were DPCs who were approached to basically become management of higher risk populations.
Right.
Is that still happening, or is that one of those vestiges of the early DPC that
I think
disappeared?
you get approached from a lot of unexpected places. I mean, I think most of us work with small businesses in some capacity. Some of our DPC colleagues work with very large businesses, and nearly their whole panel is made up of employer groups. I think that because a lot of employers are starting to recognize the value of having sort of a physician in their pocket, which, and the access is so great. But it's interesting because you do get approached by unlikely suspects, and even like high-ranking people within healthcare systems and things will seek out DPC care. And that always, to me, is sort of striking because it's just interesting, that you're providing a service that they see the value. They see it and it resonates, but they're just in a different model.
So, you created a model, a DPC model. You didn't create it, but it was created, back.
Started the whole thing.
Exactly, way back. In the day.
I remember Dr. Dahl mentioning this in like 2018.
Yeah, but Seattle,
2020.
circa 2004.
I have an idea.
I remember. Yeah, I have an idea. So one of the big selling points for physicians when you're being recruited by a large health system is systemness, integration, access. I can look at the health record and see everything else that has been done within the system. Even amongst the different organizations now, there are mechanisms. So I can see a little bit of what UPMC is doing.
Right.
And they can see a little bit of what I'm doing.
Right.
But you guys are small potatoes.
We're the fringe.
You're the fringe. You're right there. How do you navigate that kind of challenge of you're a part of the medical community? I will say that as a York County Medical Society.
Thank you.
You are part of the community.
Feels good.
But that's good for that, and a couple of bucks buys you a cup of coffee. I mean, but how do you navigate that space? That now you have exited kind of the network, as it were. Is there a mechanism or a process to stay engaged in those spaces?
Yeah, so it gets a little spicy sometimes. I'll be honest about that. So when I started, you're right. When you are, say you're out of training and you go into sort of an employed, like a hospital system-based practice, there are a lot of benefits there. And when I'm having conversations with colleagues who are considering DPC, again, I'm very transparent about the pros and the cons because there are a lot of pros to working in those situations. And direct primary care is not right for everybody. And it's not a one-size-fits-all solution, but the connectedness of it all is certainly a benefit. So when you leave, and especially when you're new and starting, it feels different to not have your orders just show up in Epic or whatever system they're using. In my experience, and I know this varies a lot, DPC to DPC and system to system, I did get a little bit of pushback about asking for things like read-only access, where I would just be able to log into their system and see patient charts. That being said, it really functions like any private practice used to. So it's not that different. If I'm sending a referral, they send me their note back. If they don't send me their note back, I call and ask for it. So sometimes there's a little bit of chasing, but it's very, very doable. I think it seems worse than it is.
So, and I think I went in as an employee to a private practice for 7 years, and then we were acquired by a larger health system for 3 years. So, but for those first 7 years, we used a EMR that nobody else had, so it didn't integrate. So I think I was so used to that, and it was fine, so I just survived. I was put into touch, or I reached out and with UPMC, with WellSpan, and I have Epic CareLink, so I can actually put orders in to Epic, and I can get all of the reports. So it is fairly easy to integrate that way. The challenging part is that other providers and doctors, I hate providers, but
We're going to say providers. No, we're going to say physicians.
It's the doctor's lab.
yes.
It was
So
yes, indeed.
so other physicians can't see my notes, right? So that's the big thing. I can see everything, but they can't see my stuff. One of the other issues, and I actually just talked to this patient today, she's in the hospital right now. She gave me permission to talk about her because she is getting her anticoagulants from me. So I'm supplying them. Hematology wrote the prescription, but I'm able to get them for $200 cheaper a month. So she's getting, or for 3 months. She's in there with a blood clot. They said, oh, you're non-compliant. You're not taking your anticoagulation. I am. But my doctor's giving it to me. It doesn't work like that. So the hospitals actually called me to verify because they actually called the pharmacy too. They said, no, she hasn't had her anticoagulants filled since June. And they said, well, let's just send you home and you can continue on what you were on. And I'm so glad she pushed and advocated because she's like, I have been taking this. She failed this anticoagulant. So now she needs another plan. And if they didn't call me, that would have been huge, you know? And so that's the big issue, I think, is others not being able to see my stuff too, not just the other way around.
It really does make you have a strong emphasis on communication. Like when I used to place referrals when I was, hospital group employed, I just placed the order. I wasn't writing this like long narrative with that referral. I just sort of was placing the referral and they could see my note, right? So that kind of, they put 2 and 2 together and that, there was a diagnosis code that went with it. When I'm sending a referral now, there's like an old-fashioned referral letter that I'm writing. Dear Dr. So-and-so, this is Mrs. So-and-so, and here's what we've done so far, and hopefully I'm giving her to you, sort of all teed up and on a platter. Here's what my concern is. Here's my cell phone number if you need anything else, Dr. Dahl. And that's what I get back. And it's really interesting because I get letters back that are like, and even from some of the same docs I used to refer to in the community, where what I would have gotten previously was just the note. Sometimes I'll get a letter or a phone call or a text back. Hey, Dr. Dahl, I saw your patient today. And so there are sometimes extra steps. I agree with that. But it really does feel a little bit more old-fashioned.
And I've been
in
able
that
to
way.
get more doctors' phone numbers. And
Yeah.
I think that's great, getting on the phone, connecting with people. Funny aside, in August, a few weeks before I'm starting my brand new practice, my son, who is 5 at the time, almost 6, whatever, he has my phone. We're driving to Ocean City, has my phone, somehow deletes all of my contacts. And my phone had not been updated because the cloud wasn't updated. It was all full. Oh, no. So anyone that I put in after a certain year was just gone. Oh, no. I was like, are you kidding me? I was like, all of these contacts. So that was kind of tragic, but I am building it back slowly.
All that makes me sad. You warmed my heart when you said I put these letters together and I did that.
Nothing
because
if not
back in the
long-winded.
day,
They did that,
pre-electronic health record, when we used this thing called paper and the charts were a gajillion inches thick, that was what we did. Literally with a dictated letter to the
But
specialist
it's so
to explain
meaningful
that.
and it's so helpful to the patient to not expect them to perfectly, especially if it's a complicated case, which hopefully is when we're sending referrals, right? We're relying on our specialist colleagues when there's a real indication there. And it's unfair that we ask patients to be sort of our translator. And if they forget something, the whole appointment becomes useless. And that happens so often. So I recently had a patient who had
Even in the system.
Right, even in the system.
Yeah.
I had a patient recently who had very vague symptoms, but they were concerning. They were sort of, things that can be quite sinister if, worst case scenario. So we had done this really thorough, diligent workup and then ultimately had some labs come back abnormal that were sort of unexpected, and ended up sending her somewhere, but wrote this long letter about the workup. And what I got back was, we're so glad to see she had X, Y, and Z. We agree that with ruling out all of these things, here's where we are. And it was the most collaborative, supportive, and I didn't always used to feel like that, you know?
You know, you're getting to something that's kind of important to me as well, is the medical community aspect piece.
Yes.
Like, and I'm struggling with this from a medical society standpoint. I'm struggling with a little bit from a physician standpoint. You know, like this is my tribe kind of thing. And you know, we used to have these things called grand rounds, and people showed up.
Right.
And you would develop these relationships over time, and you would curbside consult them
Right.
about X, Y, Z thing. And that kind of familiarity with each other, I think, led to really outstanding collegial workup, cooperation. You were less likely to shoot your mouth off. If somebody did something unexpected, you would actually pause and go like, maybe they
Assume
did
good
something
intent,
that
right.
I was missing and they're actually fixing something. And that provided better care for that patient.
Right.
That ultimately was the goal of all those conversations in those spaces. And we've struggled with how we've lost this. COVID, I think, put a fork in it a little bit, but it was already happening long before this. The electronic health record really pushed us on this
Right.
into this much more time constraint, compressed space. And what is the answer to this?
Right.
And I don't think there's one answer to it, but I am heartened by a little bit of the conversation here because this is part of caring for patients directly to kind of, you know,
In
twist it the
family
other way.
medicine, you're the quarterback.
Yeah.
And like, do you feel like the quarterback when you don't know anybody that they're seeing and you don't know your patients deeply and you don't know their preferences and you don't know, you know, like that's such the core of what we do. And having patients say, can you please recommend, I had one 20 minutes before I got here, can you please recommend an ENT who does this specific thing? And it's like, yes, I can. I was chatting with him last, and it's just so nice to be able to really have that level of connection with patients and also with your colleagues where you're like, I know they're in good hands. Like, I know that they're going to see Dr. So-and-so and they're
That
going to
makes
do the
such
right
a difference in terms of the buy-in from the patient.
Yes.
I mean, it's a completely cheesy thing to say, but man, we all know it. When you
important.
say, I'm sending you to this because I know this person, I am referring you to that person.
Right.
They are the best in the area for this individual.
Right, and
I'd
it's a bad
send my
feeling when
mother
you don't
there,
know.
let's say.
Right,
Yeah.
it's a bad feeling when you're like, I don't know any of these people. And that's hard. It's hard with turnover and how fast things are changing and people are moving practices.
I think the
tricky.
change is a big part because it's the reason I want to do DPC now is because I've noticed this change over the past 10 or 15 years. And I used to think, let's join a system because of the value of the systemness. And
Right.
what I think I've noticed is it's counterproductive. What happens is you build this system and then everybody's acting like it's a system and you're not acting like it's individual people or individual doctors. You're just saying, I'm referring to whatever specialty. And it's not a doctor. It's not even an office.
when
It's
you
just you're putting in an
request
order.
that,
Right.
Yeah, they do not. Yeah.
Yeah, and so it goes back to the transparency and accountability thing. Like if you're just part of a system, well, you're not really responsible for the patient because you've got 2,000 patients.
Yeah,
And
that
you can't really
ownership.
pay that close attention. Come on.
That ownership is so important.
Yeah, the system is taking care of the patient.
You have
It
to
takes
be
the individual out of it.
Yeah.
Yeah, I mean, that's still a thing that, you know, the young learners drive me a little nutty with that, right? I mean, because there is a part of me that it's just like, this is personal. When I'm taking care of a patient, it is personal. I'm spending my time doing this, okay, my time, but it's deeper than my time when I'm working with a patient. And I want that to be communicated to that next generation. I want them to understand this is a privilege that we get to do this work. And it feels cheapened somewhat when you're placing an order to a non-specific whatever, and you don't know for sure what is on the other side of that I'm referring to.
And that weight is palpable in direct primary care, I will say. So many of us go into DPC and we're solo, which is unique because we're used to having colleagues to bounce things off of. So that kind of turns up the heat a little bit. But also the weight, the heaviness of that a patient is coming to you directly. They're seeking you out. They're choosing your practice. Your responsibility to them to take care of them and look out for them and, you know, be mindful and be thorough. That weight is palpable. It can be hard. Like when you have a case that, like this woman that we were working up and it was very vague. And I don't think it was vague like we're not doing the right things. It just was that kind of case. And cases like that will weigh on you and keep you up at night in a different way because you know this lady, you know, like it's just such a deeper level of connection, I think. that it can be heavy, but it also is kind of the beauty of what we do. And I think that investment from both patient and physician is so, I don't know, is it like you've been doing it, like it's a
absolutely.
recent change. So
It's
do
very
you feel that
humbling.
differently? Yeah.
It's very, yeah.
So what's new is old again, or what's old is new again, depending on how you look at
An
it.
old
right?
woman.
Yeah.
No, but
Old soul.
no, but it is that thing. I mean, medicine at its best,
Yeah.
we all carried that weight.
Right.
I mean, that's when we were practicing the right kind of medicine. I will argue.
Right.
That was.
That's
really-
exactly right. That's exactly, and it's like we've tried to engineer it out of the process,
Right.
and you can't take that out of the process. That's what does it.
Because the
That personal
patient
connection is what makes
is
it work.
left lingering.
Yeah.
Like at the end of the day, if you're not carrying that weight and thinking on their case and guiding them through it, there's just a patient floundering, looking for care.
And even, referring people. I have very specific people I like for certain things. And
Oh,
I
yeah.
said, I want you to see XYZ for this problem. I'll put it in the referral. And then it goes to the central referral department. And then it just
Get me
gets taken
started.
care of, regardless of whose name is there. And then I have a local optometrist that I really like. And he would always get people in for urgent needs. And he said, I haven't seen anyone from your office recently. I said, that's odd because I'll say I want it. It was frowned upon to pick up the phone and you make that call. We had to trust the process. And we had to leave
trust no one.
everything. Yeah, exactly. And I'll admit, and my prior staff will say I'm a micromanager because
Yeah.
I don't trust anyone and I don't trust the process. And if I could, I would do everything. And now it's a lot more responsibility, it's a lot more weight, but I know the patient is getting that right care and the referrals to the right people.
You're talking about the weight, and the responsibility that you're a micromanager, but we started this conversation saying I wouldn't trade it. I feel like I have my life back. That it's highly satisfying. How do you reconcile those two things?
It's hard. I mean, it's hard. I think that, and you hear a lot of thoughts on panel size in direct primary care. You hear critiques of it because of physician shortages that were worsening the physician kind of access to care. So there's lots of different thoughts on
My
that.
patient panel would be 0 rather
Right,
than
and that's always kind of my argument.
Yeah,
It's like, well,
yeah.
people are leaving the field left and right. We're dropping like flies. People are not going into primary care. We had so many unmatched residency spots, So, I think you could probably get into a pretty good argument about, is it better to just keep scaling back on your hours to make it survivable? Or is it better to keep a smaller panel and sort of invest in them wholeheartedly? Anyway, there's argument there, but DPC is not sort of an easy way out. And sometimes you will hear it touted as that. If people are feeling burnt out in the system, if they're feeling like, I have to get off this treadmill, the workload is too much, I'm charting late at night, you will see people suggest direct primary care to kind of claim their life and get their life back. Once again, I'm always so honest and balanced about it. There are pros and cons because in some ways it's heavier because you can't clock out. I'm having a whole baby, and people are like, well, who's gonna, me? Me, like I will be managing, So there's not this built-in coverage. There's not this just ability to kind of put it down. And I'm not downplaying. I don't think most of us, even when we're employed, we're not taking it that casually. But I'm just saying it's a different level of individual responsibility when you have a practice, especially a solo practice. But I think when the work feels so worthwhile and you feel so connected to your patients, it's just different. And I think that the work of medicine isn't what most of us mind. It's the nonsense. It's like
being devalued. It's being
right.
yeah.
It's the unnecessary work, and it's the treadmill. I have to see 20 to 30 people. I'll spend all day noodling on tough cases and working with people and sitting there interacting with my patients and not feel the same fatigue that I felt spending the same exact hours, but going door to door to door to door to door.
Yeah,
So it's just different.
I love working. I absolutely hate wasting my time, though.
Right.
And that's what it is.
Right.
It's like, oh my God, I could have taken care of everything you need taken care of, but I can't do it because I
Right.
don't have. This is not set up the way it needs to be
You
set
have
up.
to trust the process.
Right.
It doesn't work.
Right. And so I feel bad about myself. I feel bad for the patient. We did a crappy job, and it cost too much money. So it's like,
It's really, that
Doesn't make
moral
any sense to do it
injury,
that way, and I can't do stuff
really
that doesn't
hard.
make sense over and over again
Yeah.
because it starts to drive you crazy.
Yeah. So getting to let go of some of that stuff, even though like I might work more hours now than I worked when I was employed. That's not a might. I work for sure a lot more hours now.
I heard about your hours.
I-
You were setting this up.
Your girl is there at the office, but it's different. It's my office, and it's lovely, and it's
You have
it's
control.
good, and I have control. And if somebody, I have these situations pop up where somebody's catching a flight, and oh my goodness, they have something and they need to come in, and I meet them at 6 o'clock in the morning in the office. And is that something I would never have had to do before, and I wasn't really, on the hook for before? Yep, but like, great. It's just such a nice thing. That's what family doctors do. So it's so meaningful that you're like, okay, like, fine,
Yeah, I used to laugh about it when I was
wash.
in training. Like, Doc Smith, he was the best doc ever. Like they'd be like family docs that don't know what they're doing. Doc Smith really knew what they were doing. Like the generalist who did no residency training.
Yes.
And had that thing, right? But what made a difference in people's relationship with Doc Smith was Doc Smith was there.
Was there.
Was present and was engaged with them. And there
Yep.
was nothing that kind of there. So I always used to laugh at the story about that. I'd be like, there's an irony in what you're saying, and I don't want to point it out to you because
Right.
I'm a
better
smart
you
aleck
don't
doing it. But the joke's on me in a sense because Doc Smith figured out something that a
Yeah.
lot of us are rediscovering now a little
Right.
bit, which is the primacy of that relationship and being and carrying that weight, but also that responsibility, but also the joy that comes with it.
And if you show up for patients like that, again, for what most of us are charging, like it just becomes a no-brainer. Like when I was building my practice, I was thinking very much of other people in my position. Like I was a mom with young babies, and I wanted to build a practice that parents with young babies would really feel connected to and would feel like was valuable for them. And I'll tell you, when it's 2 o'clock in the morning and a patient, texts me a completely black video and it's the sound of their child coughing, and you know that they have croup, and you just handle it, and you say, come into my office and we'll just we'll just give you the when you just take care of it. That one interaction carries that patient for a really long time because it's not that people are asking for so much, but like, look at what they're up against, like the alternative.
And they want people to show up. They want people to
Yes.
care. And, I, with just starting out, and I don't know how prepared you were, but I was worried, I don't have all of this. I don't have this equipment yet. I apologize to patients. The labs weren't set up yet because it took forever and a day. But every single person was like, that's fine. I just want you. Like
Right.
they want to be heard. They want somebody to be their like partner in health. They want somebody to advocate for them. So I think just showing up is
Yep.
half the battle in whatever capacity.
Yep.
And I think that's huge.
I can tell you a big thing that has motivated me to try and do primary care is Dr. Dahl.
You get out of town with
She
it.
takes care of my family.
Stop.
Without a doubt.
luck.
And Dr. Dahl and Revival Direct Primary Care were there when the local systems were not available and we really needed a competent doctor. And what was great about Dr. Dahl and Revival is I could talk to her. I could call her number or send her a message, and it wasn't going to some corporate behemoth where an AI is going to respond to me. It was going to Dr. Dahl. And Dr. Dahl said, sure, we got that, no problem. And it just gets taken care of. And so what was so valuable for my family was just her being there, the access to her. It wasn't some special fellowship training about something complicated medicine-wise. It was just being able to have someone you could go to. So.
Yeah. Thank you.
There you go. There was your pretty good information.
That was a really good build up. My practice is Revival Direct Primary Care. I opened in 2021. And people ask me all the time why the name Revival. And obviously there's reviving health and like there's that kind of not. But really for me, it was kind of a nod to reviving my love for medicine, but bringing back old-fashioned care. So it was a revival of old-fashioned family medicine. It's actually what my whole practice is sort of based around. So fits with our conversation. But yeah, I'm revivaldpc.com and Revival DPC on all social media platforms. I don't know. It's
How
just
cool is
me.
that?
I'm just one person.
All right, so Lauren,
Yeah.
tell us a little bit about yours.
So I'm True Care Family Medicine, True Care all one word, and I just wanted something that kind of was common, but brought out what I was delivering, right? And so I truly care. I'm going to provide you with true quality care, and obviously full spectrum minus OB family medicine. And I don't have a fun backstory. Like but
I stressed on for months.
You
over
will
the
soon
name and
enough.
the
yeah.
That's how
But
this goes.
we're truecarefm.com, and I'm on Facebook and Instagram reluctantly. I don't do TikTok. I didn't have Instagram until I did this.
gotta be on
I'm
the gram.
old.
It's public, I'm told, from
Horrifying.
the CME I've taken. That's why
You
you
have
want
to do it. You have to do it. And it's neat because as you grow and evolve, you get to kind of use those platforms and announce different things. Like when I started, I was purely, obviously, family medicine, went on to do board certification in lifestyle medicine and obesity medicine. So like got to share that with patients as I kind of added those things. And social media is a nice way to kind of, have I updated the website? Probably not. My IT girl,
You have to take it up with the IT girl. Absolutely.
just trying.
But
But
it's fun being IT and cleaning
All
and
the
the
things.
MA and the phlebotomist. I wear a
All
lot of
the
hats.
Phlebotomist.
I am the phlebotomist.
vaccine inventory is the one that, like, if I could just have someone. Oh, jeez.
That's a tough one. I will say for folks who, when I worked in public health land, we would have good, well-trained, excellent physicians in the office who I trained with, who then said, can you guys handle the vaccine inventory? I literally going to send
Really?
them over to you. Can you just do the vaccines through the public health department? And
Would
I'm
you
like,
like to be the department chair?
yes, we can. But,
Yeah.
but it's a challenging space. It's
Yeah.
hard. One, people are hesitant with them, but two, just maintaining it adequately in a way
Yeah.
that meets the standards is a challenge. It's hard.
Yeah. There's so many hats that you wear in DPC, and it's such a learning curve, like Lauren was saying. It's just there's just things that you never had to think about before that suddenly it's your day to day, and you don't want to end up in the spot like someone walks in and they need a procedure, they need something, and you don't have what they need. That's the worst feeling. So all of those kind of things that just quietly run in the background that you were used to, like supply inventory, someone going through things and making sure all of the out of date stuff, because everything like the alcohol swabs expire. Why? Just why? But just all of those things become your job. But again, it's kind of neat. It's kind of neat to know the ins and outs of every single aspect of your business. I don't know.
All right, sir. This is your moment here.
Build it up. Look directly.
First Cap Care is the name of the practice. Is the name of our practice. That's a nod to York, which by some minority. A minority of historians would say that York, Pennsylvania was the first cap of the United States based on the signing of the Articles of Confederation when we had retreated from Philadelphia as the
Run away.
evil British trying to get us. Run away, went away.
Talk about a story.
I know.
That was better
And-
than mine.
I'm from York, so I'm York to the core. And so what First Cap Care is really supposed to be is like it's York care. And in York, we're not fussy. We just want you to get to the point, get the job done. And that's what First Cap Care is designed to do. We're sort of like bare bones, high quality, but no more than you need, and as cheap as we can make it. And so that's our pitch at First Cap Care.
That was good.
There you go.
Yeah.
Working on that.
Elevator.
Is there anything that we didn't cover tonight that you guys want to make sure that, I think we did a great job of getting kind of the breadth, the challenges, how you kind of got there, what behind the curtains, the challenges behind the curtains and those sorts of things. Is there anything else that you want to add to the conversation that you want us to take away at the end? Like this is like, if I'm considering this in the community. I'm actually not, but hey, I'm considering.
Come on.
The community. Yeah, you never know. Come to the dark side. But pitch it. I mean, why is it a good idea? I think we have some things done, but if you were trying to close the deal, what would the deal closure be?
I mean, just in general, like my husband was saying, I wish you had competition. Like he thinks that this should be the future of medicine. And I really do, because it's going to be better for patients all around. It's going to be better for physicians. It's going to be better for the community of physicians and doctors and just collaboration. I think that it's that direct access, affordable care. I think it's a no-brainer. And my only regret is I didn't do it sooner, but I don't think I would have had the confidence to do it sooner.
That was actually going to be my comment was going to be on having the confidence. I think that for a lot of us in medicine, our training just sort of repeatedly beats into us that there's always someone better and more superior, right? Like our whole model is built on a hierarchy of, when you're a med student and then you're an intern and a resident. And I think for many of us, and I'm going to go ahead and say, especially in fields like family medicine, where I feel like we don't always get that same level of credit or that same, clout that might come with other fields. I think that a lot of us look at doing something like direct primary care and think that it's like a pipe dream. And what you find when you kind of even just put a toe in the water in the DPC community is that it's a super collaborative group of doctors. And we, by and large, like the whole group goes with the like a rising tide lifts all ships kind of, vibe. So we support each other, we work together, we are very, I think, friendly overall and help people as they're growing and developing their practices. And many of us don't have MBAs or formal business training, and that can make you feel some of that imposter syndrome when you're going to open a practice. But we are smart enough to get through medical school and residency and hold people's lives in our hands, and we are like, these are capable humans. And my message would be that if it's something that really resonates with you, that it's worth exploring, because you're going to find a really friendly, supportive group of physicians who will help you get there, and patients love it. And so if it's right for you, I think that it's just knowing that it's doable. Because for many of us, I think that that first step and feeling like I could never do that, or, the risk. You started to talk earlier about like what the risk involved, and we didn't get into that too much, but a lot of people are very fearful of that risk. So I guess my message would be like, it's worth exploring.
And just to piggyback, unless you want to go first.
No, I was trying to remember what the question was that I was going to say.
It's me and my answer.
No,
It really got away from
that
me.
was an example of me thinking about what I'm going to say rather than listening to what you're saying.
Sorry, guys. Sorry.
So,
The Rambler.
one, I guess the 2 points are, I went to the DPC Summit in July. They have this big annual summit every year, and they're having it in New Orleans again this year. If anyone is like curious about it or questioning DPC, and they had all levels there. But when you go to a medical conference, and you just went to one recently, and people barely look at each other, it's like tunnel vision, everybody has their computers open the whole time, nobody's listening, they're just there for the CME credit. There are 500 people in this room. And most were doctors, some were office staff, things like that, family members, but 500 people in this room. Every single person was happy and networking. I didn't see a single computer out. And
We like
whole
know,
weekend.
you all know, everybody knows everybody.
It was
in
like
DPC.
so
It's wild.
weird to see happy doctors.
Yeah.
Like it was surreal.
Yeah.
And the other thing that I took away from the conference, I think is so important, especially if anyone's considering opening something, is that they have a saying of, once you've seen a DPC, you've seen a DPC, because you can create it however you want to. There's so much flexibility. You make it what you want. It's your baby.
Right.
Yeah. And so I would say if this is a closing argument for physicians to get involved in DPC, I think watching the 2024 DPC Summit that the AFB put on would be a great idea for exactly that reason. And that's part of what I did 6 months ago. Was I was watching that, I thought, oh, wow, this is doable. And that was a big motivator. I think from the other thing that motivates me is I just want to do my job well. And so if you're a doctor and you think you're doing your job really great in the current system, keep doing it. If you think you might want to try and do a better job or feel better about what you're doing, I think direct primary care is a great opportunity to at least have some hope in being able to do that, which is, I think, a good thing.
And I think every DPC physician, York is growing. Lancaster has a pretty thriving direct primary care market. Reach out. Just like we call specialists and kind of communicate like that. I've had quite a few people over the years reach out and say, can I just stop by your practice? Can I look at what this looks like? Can you walk me through a day? And I think any of us in direct primary care are so excited about it that we'll gladly spend time with you at a coffee shop or whatever, going over things. And most of us are very transparent, what it costs to set it up, how quickly we're profitable, all that kind of stuff. You'll find a lot of transparency, just like in the model, with the people who are running the businesses, because I think we're all really invested and on board. Like, wouldn't you agree? Right at that conference, people are just like willing to tell you.
Yes. And on the
there's no
different
gatekeeping.
Facebook communities
Yes.
and things like that. People are so amazing. I met so many great people there that I still talk to.
Yeah.
But you don't have that kind of collaboration anywhere else. Like, even in residency, I didn't feel like that. And, you know, you have this support that you can talk to anybody about anything, and there's like zero judgment, there's help, it's a wonderful, wonderful group of people. And so, yes, I would love to pass my knowledge on to other people too. Because
You're going to create hot competition if you're not careful here. You're gonna
hey, that's what we want.
Like,
yeah.
Oh, it's like you said, that helps. The more you get, the better.
Yeah.
You build a
Our
critical mass, you
panels,
support each other.
You know, at my other practice, they wanted me to have 2,400 patients. I had almost 2,000. My goal here is less than 400. So, because then that way you can give people that individualized attention continuously. So we'd need that competition.
And honestly, like, I think we're so happy to recommend, like, I'll do meet and greets with folks and be like, oh, you know who the perfect DPC doctor is for you? And I'll be like, are you willing to go to Lancaster? And that might seem so odd because here's someone coming ready to pay me money to do this business. But if they're looking for, you know, XYZ quality, and I know, like, there's a doc in Lancaster who does pretty much strict geriatric care and a lot of evaluations of, like, home safety and all of these things. And I had someone reach out who was looking for that to a T. And I was like, I can do this for you, but there's someone who's a complete expert and is not that far away, and I can just tell you would love. And so I'm like, I'll be the first one to give them their name. And if they come back, that's great. And, you know, and if they feel like you're the best fit for them, but I think we're all just so excited to move the model forward that there's not a lot of, I don't know, you know?
I hope. Yeah, that's the way it seems.
Try me, you take one.
That's what it's like. Stay over there in West York, Harberger.
Awesome. Hey, thank you for your time. Thank you for your wisdom and sharing this information.
Thanks for having us.
Yeah, I feel like I have learned a ton. This is definitely DPC 101 for sure, and hopefully this is helpful to folks who get to watch it. So thank you for the value when it comes to working in primary care. Time is money. Everybody likes to say the business rules or whatever, but recognize this is time away from not just your business, it's time away from your families, it's time away from those other pieces, but it's a gift. So thank you for the gift of your time and your energy today. So thank you.
Thank you.
If you're a medical student and you picked the second year, I thought that was an interesting one, right? So we all know second year, you've had your nose in that book for a year plus. Say end of second year, you're getting ready to go into the wards. You're getting ready to learn how to be a real doc now. And every time you get to the next step, they always say, now you get to be a real doc. And you're like, yeah, I'm not sure when that happens. But what do you say to someone who's like halfway through their medical school training and to say, how do you encourage them along the journey to get to the place where DPC is a viable option for them?
So that's a really hard question. And I only say that because the problem with direct primary care, one of the big problems, is that you don't have people to collaborate with. And I feel like I almost learned more the first few years after residency than I did in residency. You're going to learn from the volume of patients. You're going to learn from having people that you can bounce questions off of. So even though this is a wonderful model, I don't know how well it would work for somebody straight out of training. And so I kind of say that with a grain of salt, but I think that if that was their long-term goal, or if that's what they wanted to do, then, thinking about getting different sub-Is or different rotations in even like more rural areas, getting their core skills built up. But it's isolating at times. So if you don't have that community, that would be my biggest concern, if that makes sense.
To me, just from the outside looking at it, I hear what you're saying, and I'm like, I think that's maybe the next part of the next generation of DPC, where they do have to figure out how to not formalize it, but how to deepen the connectedness and that ability to bounce ideas off of each other and to feel connected. It is one of those things early in training. I don't know which one of you were talking about it, but you were talking about like the first year out of whatever, and I used to do you were talking about all the different things I could do, and then you get shoehorned into to just being you just do primary care and the X number of minutes per visit kind of thing. And where I went to a place that said, what, you can do it? You don't have to push your way. You have to actually say, no, this is where my limit is. You had to actually establish limits when you were doing more rural medicine, because they want you to do the crazy stuff. But my first fracture or dislocation of an ankle that I ever saw in my life was within 3 months of working on an Indian reservation. Yeah. And it was a football player, and I would never have seen that anywhere in York County, Lancaster County, South Central Pennsylvania. But here I am in the emergency room going, well, this is going to be an adventure, right? Right. And having those folks around you to support. Now, in that context, what did I do? I called my orthopedic colleague who was, the hour flight away in Flagstaff, and I said, I got this thing. And he's like, this is how you take care of it. And if you aren't able to take care of it, fly them to me. And if you are able to do it, this is, these are the two parts of the plan. And his hope was that I would be able to take care of it. He didn't want to be in the OR that night. Right. That was his plan. But it was a whole different way of practicing, and it was a way where there was, even though it was not direct, it was indirect connection to the specialist colleagues who were actually in your corner the whole time. Sometimes in residency, you felt like you had to carve out your corner. There, they were grateful for you. Keep doing what you're doing, and send them to us when you need us.
I think this is a really cool question, because as DPC grows, it's already grown so, it's amazing to see just how quickly practices are opening, and it's exciting to watch. But as it grows, and as a physician community, people are more familiar, I actually think there's so much room to generate excitement about primary care that is deeply lacking right now. I think that if you scroll social media about primary care, or you look at, the med students now and residents have very active social media platforms. And when people talk about going into primary care, family medicine, there's a lot of not so positive comments and feedback because of what everybody thinks it looks like. So I think actually getting to show learners what it can look like opens up this amazing opportunity, because I think there are people that would be very drawn to family medicine and primary care if they knew that they could have a practice of their own, because so much of medicine now is working for someone else, and there's so many fields where you just simply can't have a practice like this. Yeah. And so what a gift it is to be able to do that. But there are so many people that would love to practice cowboy family medicine and old school family medicine, right? And who like that when they get to see it, but they just don't see it. So showing that, letting students rotate with us, being, one of the most fun things that I get to do is give talks at colleges and med schools and residencies and talk about what direct primary care looks like, because so many people haven't heard of it, and they're just like, whoa, this is different, and maybe I would pursue that. So I actually think that it's cool to think in that perspective. I would encourage a student going into direct primary care to be very hands-on, to take a lot of ownership and get used to that feeling. Master as many procedures as they can, and look at it as many skills as you can develop. They're just tools in your tool belt, and fewer things you have to refer out. The more you can do and master and keep in-house, the more your value goes up for your practice. So
I would love for all those second years to want to do that.
Right.
It's just a matter of getting that exposure.
And which is hard.
Yeah.
It's a hard.
Yeah, I think that's a great question, and I don't know that I would tell that second-year medical student anything in particular different than I would if I wasn't talking about direct primary care. What I would focus on is, doing medical school and your training experience to try and see what you like and get into everything you do. And the people who really get into primary care or go into family medicine, they're going to find direct primary care. They don't need me to tell them in their second year they need to do something about it. They need me to tell them, you need to follow your dreams. Don't give in to just whatever the dean tells you have to do, because that's how medicine works. Just try and do what you want to do with medicine for the reasons you want to do it, and it'll take you where you want to go. And direct primary care is going to be there, I think. I don't think you would necessarily have to give them a pitch or some sort of step they have to take.
It doesn't hurt to lead them along. Give them a little tug. Because so many of us never knew it was a thing. Like, I don't know how everybody found out about it, but I still have so many colleagues who have no idea what it is. Colleagues in primary care and other specialties, and they're like, what the heck is that? So I think that being as, not
about
annoyingly
it.
so, but being vocal about it is important because it's like a little hidden gem.
It is totally a hidden gem.
There you go.
Maybe
Oh,
it's not.
it's not so hidden anymore.